On est des jumeaux de bureau.
Lui, tu l'as juste trouvé dans le couloir, il flânait quelque part là, avec son vélo.
Actuellement, je l'ai trouvé sur le bord du chemin de Montréal, fait que j'ai dit de venir.
OK, ben on va commencer. Merci tout le monde d'être là. La présentation aujourd'hui va être en anglais, mais Grace parle très bien en français. Ça peut répondre des questions dans les deux langues. So Grace, aussi une de mes amies, dans la même classe de médecine que Anthony, qu'on a rencontré la semaine passée. She decided to go into palliative care and ophthalmology. Also same class as Olivier, who's probably hiding in there somewhere. So Grace is palliative staff at the Ottawa Hospital, also the residency program director. And the idea today was we have great palliative consultants, just that a lot of times we can't talk to them. So the idea is, and we have a great order set, but the idea was just talk about some stuff in regards to palliative care in the emergency department. And Grace is totally open to questions. We can stop her anytime, and I'll watch the chat. Go for it, Grace.
Awesome. Thank you so much, John, for inviting me. As John said, I'm trained here in Ottawa, went to the French stream for my medical school, so delighted to answer questions in French or English. Just a little rusty on my French, so you'll have to forgive me at times. I'm really seated in this talk, grounded in this talk with the idea that, like, if you guys are alone at night with nobody to call, kind of what do you do? And that's kind of where we're going with this. The daytime is perhaps a bit different when you have your palliative consultants available, which is why the talk is entitled Palliative Pearls for the ER Doc at Midnight. I unfortunately have no conflicts to disclose. Palliative care is not a sexy pharma type specialty. So there's that. And I think we'll jump right in. So the objectives I was asked to speak to today were to talk about the most time-efficient strategies for end-of-life talks and goals of care setting, to review the end-of-life order set, and particularly with a focus on managing end-of-life agitation, what would I do, and the quote-unquote death rattle. I was asked to talk a little bit about an approach to withdrawal of high-flow oxygen, and that's the part where I foresee, having a bit more of a discussion if you guys are interested. And I've included some of my favorite palliative resources at the end that I think can be really valuable. As John said, interrupt me anytime. I'm delighted to answer questions like, well, I had this case one time and this is what happened, and that would be totally fine. If this whole thing derails into a question and answer section, that would be totally fine with me. The bottom line is I'm hoping that you guys will feel confident in having an approach when you see somebody that is at the end of life and you are all by yourself at midnight. So I want to start by grounding us in what I foresee your role to be, as opposed to having, a specialist palliative consultant 48 hours later with all of the benefits of hindsight of 48 hours into the admission. So what I foresee the role of ER being is recognizing when someone is approaching the very, very end of their life, confirming broad and immediate goals of care, so not the nuanced nitty-gritty necessarily. Stabilizing the patient as needed, and this may vary, of course, based on their stated goals, to provide education and to start immediate symptom management, and then determining the immediate next steps. I think that the real focus that I want to put on is education and starting the immediate symptom management. And just to contrast with what I think the role of ER is not for palliative care, I don't think it's to have long and winding and nuanced conversation when there's not sufficient information available. I don't think that it's to discuss treatments that may or may not be available in the long term. There's lots of other time and people to do that. Planning complex discharges, obviously not, and resolving family conflict, which inevitably arises. So we're going to walk through a little bit of a case. This is Mr. Hypothetical, and Mr. Hypothetical is a 77-year-old male from home with a supportive wife. They have 2 children, and he does have some needs for some regular ADL support at baseline. His past medical history is he's highly comorbid, he has advanced COPD, he's on 4 liters of oxygen at home. And then 2 months ago, they found a new lung lesion that he decided not to pursue any further investigations or treatment for. And he said to his wife at the time, if it takes me, then so be it. And that's documented somewhere in the oncologist notes. He arrives in the ER tonight with severe shortness of breath because nothing has been set up for him at home. And an X-ray reveals diffuse metastatic disease. Maybe he's got a pleural effusion. Maybe he's got some carcinomatosis. He's got it to his bones, etc. There we go. And as I said, they have no palliative care set up at home. So one of the things I commonly get asked is kind of what is my usual spiel as the palliative care doctor going into a room? Because as we all know, we are a death-phobic society. We don't talk about death and dying. And people often think at baseline that I am the Grim Reaper when I'm going in. So my spiel, and you can borrow any piece of it that you like, goes something like this. Palliative care is the specialty of medicine that provides care to people who have advanced illnesses of all different kinds. Some people are very close to the end of their life. Some people are not that close to the end of their life, but they have bad symptoms from whatever their terminal illness is. Most people are somewhere in the middle. And while they have many doctors who are working hard on making them live longer, my job is to help them live better. And for most people, that means that for whatever time they have left, they have good symptom management, they have dignity, and that crucially, the care that they receive falls in line with their values and the values of their family. So that's my little get into the room spiel. And interestingly, no one has ever said no yet to talking to me about those things. So it's been pretty reasonably effective. And then the next most important thing, I think, is going into a person's understanding of their illness. And you guys see this all the time. There is a deeply wide variety of people's understanding of their illnesses. I work in a specialized dialysis palliative care clinic, and on a regular basis, people tell me that their dialysis is making their kidneys stronger somehow. So I think that if we're starting there, there's a lot of an education piece to provide to have any sort of reasonable goals of care discussion. Is the foundation is having a strong understanding of where they are in their illness. And it may be as simple as what have your doctors told you about where you are in your illness so far. And then we talk about prognosis. And so I like to ground our prognosis in the different illness trajectories. This is also something you guys will be very familiar with. So is this something very acute trauma, an MI, where the person's level of function versus time, there's a very steep and sudden decline? Most of the patients I see are in the type 2 category, so the top right. And that's your cancers, maybe your longer sepsis, where the function is very, very high. They get diagnosed with the infection or they have metastatic spread of their cancer. And then it's a reasonably steady, predictable, but quick decline at that point. And so you can imagine that talking with someone who has a metastatic cancer about their prognosis is quite different than talking with someone who's a type 3 with organ failure, your COPDs, your heart failures, your kidney failures, where they have kind of waxing and waning. The steady decline punctuated by periods of very deep functional decline, these exacerbations of their COPD, for example. So somebody who looks terrible from a COPD perspective, you guys know this, you see them all the time, they bounce back and they look like death again, but 48 hours later, they improve quite a lot. So just grounding ourselves in that prognosis, and then the kind of frailty dementia piece, which can be very long at a low level of function. So we're very bad at talking about prognosis. And so I try to not give a specific prognosis often if I can, but I will couch it in terms of in terms of my usual speech, it's something like, we're very bad at predicting prognosis. We think based on the level of disease that you have, the rate of change that you've had in the past, and based on our best education that it is weeks to months, months to years, days to hours, whatever the range is, never like a specific time, but range. But I always say that I've been wrong before. And I'll be wrong again because we are very bad at predicting prognosis. That was my usual speech. We are better at predicting prognosis writ large as doctors if a person is approaching their final hours or days. And this is where I'd like to focus in on today because we're actually pretty good at that. So signs that someone is approaching their last hours or days is terminal delirium, decreased LSC, if they've had nothing to eat or drink for days and often longer than that. Changes in their breathing. I'm thinking apneas. I'm thinking about Cheyne-Stokes breathing, having terminal secretions, and changes in their circulation like cool limbs or mottling, which is that lacy kind of purple pattern to the arms and legs when a person is approaching the very end of their life. So back to Mr. H, who's 77, COPD, and now presumed metastatic, likely lung cancer. He arrived with shortness of breath. His wife is there. And it's about midnight. And you're speaking with her, and she is, gosh, not sure what to do, but really feels that he has been suffering over the past, weeks or so, and has been declining in his overall function. You do some basic blood work, which shows multiple derangements that are non-reassuring. And you find out that he's lost approximately 37 pounds in the last 3 months since his diagnosis. He appears quite frail. And you speak with the wife and you actually feel yourself that he is actively dying, that he might be in his last days or even hours of life. So now what do we do? What tools might you use to have the discussion in this situation, which is of course very difficult? They may have some inkling that something has changed or that he's declining, but how do we turn that inkling that they may have into a discussion about how he can get his health care, seeing as he has nothing set up at home? And you can borrow from my line, my intro speech there, that I want to ensure that the care that you receive from our healthcare system falls most in line with your values and the values of their family. There we go. And the tool that I'd like to present to you is the Serious Illness Conversation Guide. And so I'm not sure if anyone has ever heard of the Serious Illness Conversation Guide. And if you are very familiar with it, stop me anytime. But it's one of my favorites and one that I teach a lot. Easily Googleable. You Google Serious Illness Conversation Guide. It's out of the CPS BC, like the CPSO for BC. And I'll show it to you on the next slide. I like it for establishing understanding of prognosis, values, trade-offs, and fears, for example. So this is the entirety of the Serious Illness Conversation Guide. And one of the reasons I thought I would teach it today is because it is literally one page and because it has some beautiful patient-tested language to highlight all the steps. And I have literally gone before in complex goals of care discussions and read it like essentially verbatim, and it has been very effective. So I want to highlight some of my favorite parts of this guide for your use, but I would encourage you to have a look at it if you're ever going into a serious discussion where you want to explore these things. So as I mentioned at the top, first establishing the understanding of illness. We cannot move forward until a person has a reasonable understanding of their illness, because if they're having magical thinking about what is possible in terms of cures and miracles, etc., it makes it much more difficult, of course. If there's one thing that I would have you guys take from this, it's hope, worry, wish statements. And I think that hope, worry, wish language, as we talk about it in palliative care, is really valuable because it aligns the language around your intention with the emotions and the intentions that a family or patient might be feeling. So they're hoping, they're worrying, they're wishing. And if you're hoping, worrying, and wishing with them, you can still be a good doctor and base yourself on the facts, but you can align yourselves with them. So for example, I wish we were not in this situation, but I'm worried that your time may be as short as hours to days, and always a range in there, for example. Or for example, I hope you will continue to live for a long time being well, but I'm worried that you could get sick quickly, and I think it's important to prepare for that possibility. So this hope, worry, wish, however you can pepper those into your language, I think is super valuable and is a pearl that I would share. If you're getting into more nuanced goals of care and want to explore that, what are your most important goals if your health situation worsens? And I often hear that patients and families struggle with, well, there's no cure. What can I be hopeful for? And this is where I like to reframe hope. So it's true. In many cases, patients I see, we cannot be hopeful for a cure. A cure is not on the table. But that doesn't mean that we're bereft of hope. There's lots of things that we can still be hopeful for. And so I encourage them to reframe that and be hopeful for dignity, for comfort and good symptom management, for quality time with the people that they love, for spiritual growth and awakening, if that's relevant. And to be in the right place to meet their care needs. And crucially, to be informed of what their options are. Those are all goals that we can be hopeful for, even in the absence of cure. And then perhaps a good one for you guys. This is a trade-off statement. If you become sicker, how much are you willing to go through for the possibility of gaining more time? Because we know that everything in healthcare is a trade. So I go through dialysis and all of the kind of crap that brings in exchange for extending this part of my life and hoping to maybe achieve a transplant, for example. But that's a trade. It's work to go to dialysis. There's symptoms that come from getting chemo. And so we're making that trade in the hopes of getting something back. And so how much are you willing to trade for the possibility of getting something back? And fun fact, it's also available in French. So I found this out last week and I Googled the Serious Illness Conversation Guide en français. And so it's not quite so beautiful in terms of the PDF, but the patient tested language is there and does exist. So if you're keen to do this in French instead, then absolutely it exists. Does anybody have questions about the Serious Illness Conversation Guide before I move on? All right, hearing none. As I said,
I was just going to say, Grace, like, especially that first question, I think you kind of hit on it and you probably see it every day, but we certainly see it, that sort of lack of understanding of people, even people that, you know, see an oncologist once a week for like 3 years, and then you ask them like how serious their pancreatic CA is, and they have absolutely no idea. So
they're fixing it. Yeah. And so I think it's tough for us to do a lot of this palliative work in people who have poor understandings. So that's where as you know, the education piece falls into things, and that's kind of the first step into helping them along. And yeah, it's easier for us to do like the quick and immediate goals of care in people who are well informed about their options and who've already had this discussion. So for those of us who are out there doing the work to kind of plant the seeds in advance before this emergency room trip, I think that's the kind of foundation of this, but certainly there's a lot of people who do not have that foundation yet, and that's tough. Okay. And then inevitably the family member will say, but if we stop this treatment, he will die. So whatever treatment X, antibiotics, chemo, dialysis, whatever. But if we stop this treatment, he will die. And this is a statement that used to like really kind of get me, and I would kind of get my back up in talking with families about this. But it doesn't anymore. And it's because I have figured out that this represents a false choice. So this statement is true. And if there is the choice, that is true. So this statement that the family member has brought up assumes that if we continue the treatment, he will live. And if we discontinue it, he will die. But that is actually not the case. In most of the cases that I see, if we continue the treatment, he will still die. So I think that kind of calling out that false choice and saying something to the effect of, you know, this is a terminal illness. We know that this is the thing that will likely kill him. We have, you know, we have this road that will get us there with lots of medical management, blood pokes, blood tests, vitals, CT scans, whatever, but we still get to the same end point versus comfort, dignity, good symptom management medications, you know, being in a beautiful room with your family, playing music, and not having to have your blood pressure taken at 6 a.m. It's a very different route to get there. So if you hear this, I would ground myself in the idea that this is a false choice and we can call that out. So back to our lovely Mr. Hypothetical. You can say, so this is a guy in COPD on oxygen at baseline, now has metastatic cancer. You think that he is dying like tonight. So some key phrases that I would share with you that I use It's like things like his body is starting to show us signs that it is ready to die. And notice that I use it is ready to die and not he is ready to die, because I think that people can more comfortably understand that bodies die as opposed to the humans we love die. So it is ready to die. And I think that's an important little nuance there. This treatment, these antibiotics, this chemo, whatever, might prolong his life, but it will prolong this part of his life. Because I think when we talk about prolonging life and getting good time, people hope that we can go back in time and get that good quality of life that was 6 months ago. But in reality, the treatments that we offer most of the time prolong this part of his life. So are we okay with prolonging now as opposed to then? And then offering a choice. It is okay and reasonable. It's a loving and reasonable choice to allow for a natural death. And that's what I usually say when people are like, well, so you're just going to let him die? And I say, yes, I'm going to choose to allow a natural death. So I think that those are some key. We have a question.
A bit of a comment exactly on that, because I've had my share of patients like that I've accompanied through either a decision to go through palliative care. And one I saw when I was in Montreal and in the highly religious, and they were saying like, oh yeah, they always like with the Catholics, like we wanted treatment and all that. I'm like, well, like it's possible right now what we're seeing, God is trying to come and get them, and I'm fighting against them right now. Like you're asking me to fight again, because obviously all the signs are, and that like tended to reframe that part, and then there's this acceptance like, oh yes, maybe it is their time and I'm fighting against their time. And I like this, like this treatment might prolong this phase of his life. Our palliative care nurse calls this like sepsis interruptus, like the dose of antibiotic to stop the actual like, oh, they're gonna die. If you give them antibiotics, they'll probably live another week while they're still dying and still happen, but they'll still be in the bad shape that they are now, and it'll just take longer. So now I've started the discussion way before the like shotgun dose of antibiotic on a septic patient that is obviously not doing well.
Mm-hmm. Beautiful, beautiful. Well done. Absolutely. And that whole idea, especially in some religious communities who feel that it's God's choice. Who are you? You don't know God's plan. You're just a mortal doctor. How do you know when God is going to take my loved one? And you're exactly right. Like he's trying right now. This is what we're seeing. And so like, we could choose to let that happen. I think is an excellent point. And then if they push back on that, I will usually, and this is not part of what I've included here, but I will usually say as a follow-up, if they push back, how will you know when God is ready to take it? How will you have known that? And that they kind of are taken aback a little bit, and they have to kind of think about what are the signs that they will see that God is taking them. And I'm like, yeah, because it's right now, like this is it. So I think that's a really excellent point. Did anybody else have comments they wanted to add? Hearing none. In the end, what I tell my residents is that people die as they lived. And it's, I think, unreasonable for the healthcare system to expect us to fix, as I say, like family strife or change people's personalities. So I also run a clinic for liver patients, and patients with kind of liver disease for a wide variety of issues have kind of chaotic lives. They don't always have strong family ties. The family ties can be a little bit chaotic. So if a person lived chaotically, sometimes they will die chaotically, and it's not possible to expect more than that. Not all the time, but when things are particularly difficult, I remind myself that people die as they lived. So based on your excellent counseling, the family is confident and chooses comfort care. And so now it's time to place some end-of-life orders for Mr. H. What do you prescribe? And so what I got from John is that there's a whole bunch of choices, and how do we choose between all of these things? And I would like to thank ChatGPT for making me this image of an owl doctor choosing medications, because I feel like I leveraged technology for this appropriately. So how do we choose between these options that are available to you, and in what circumstances do you prefer one over the other? So let's take a quick review of your end-of-life orders, and let's make it simple. And then I'll show you also a couple of slides that if you would like to screenshot, you'd be welcome to, how I order stuff at the very end of life. I would like to thank John Gravel for these very high quality photos. So the first section is IV solutions, and it talks about hypodermolysis, 700 mils in 24 hours, 1,000 mils in 24 hours. And the big secret is that I, as a palliative care specialist who does full-time palliative care work, have never in my life ordered hypodermolysis. I think that sometimes it's used in the community environment, and sometimes it's been used on the PCU. And the only time I've heard of it on the PCU is when there was a guy who wanted to live to Christmas. He was profoundly anemic and needed a blood transfusion. And we couldn't get an IV, so we used hypodermolysis to get the IV to give him a transfusion to live to the specific date. But that is the only context I've ever heard of anyone ordering hypodermolysis. So you could reasonably choose to ignore this, I think. The next one is, do you choose hydromorphone versus morphine? And so as a reminder, opioids can be used for dyspnea, shortness of breath, as well as pain at the end of life. And I've highlighted here that you have, for your hydromorphone, you have an extra small and small dose, and your morphine is actually equivalent to a little bit more. So just to be mindful of that, the ratio is 5:1. So your morphine doses here are actually like a little bit bigger than your hydromorphone doses. But I like that you have 2 starting doses, so extra small for your frail, your tiny, your elderly, your very, very sick people, versus your small, which can be the smarting dose for patients who are maybe a little bit more robust, a little bit older, who have some reasonable organ function, for example. And I like that it's Q1 hour PRN and Q4 hours scheduled. That's basically how I order all of my opioids, unless you're just starting a PRN. But if someone uses more than 2, maybe 3 PRNs in a day, I'm starting a low scheduled dose of something. Now, it doesn't actually matter which. Pick your favorite, get to know it, doesn't matter, or whatever they were on before. So if they came in on hydromorphone, maybe continue the hydromorphone. But if you're starting opioids on an opioid naive patient and you're struggling with, wow, should I choose hydromorphone versus morphine? The answer is it doesn't matter. And even those who have severe renal disease, which is often the example that is used to prioritize hydromorphone, the studies for that are limited. They're mostly in rats. And it's really for patients who have really severe renal disease with higher doses than these of hydromorphone. So yes, you can absolutely choose hydromorphone as your favorite, but you don't have to necessarily. And I have used morphine in patients with renal disease before. I saw a hand and it went away.
Yeah, Yannick, tu as levé ta main?
Grace, you're too quick. You answered the question with that comment on renal disease. Thank you.
Yeah, so you can absolutely choose Dilaudid if you wish, but you don't have to. And therefore, you don't also have to switch someone from morphine to Dilaudid if they have an eGFR of like, 30. I usually start thinking about it in the eGFR range of like 20 or less, maybe for higher doses, but I have absolutely used hydromorphone before. And so I wouldn't worry too much about it, basically. Pick whichever one you like. Any other questions on the opioids before I move on to your anti-secretory meds? Cool.
Grace,
yeah.
It might be a stupid question, but there's no big difference in volume. It's not like one is way more comfortable for patients. Like people tend to tolerate them very similarly. Okay. Like when they're sub-Q or butterfly or okay.
Yeah. There are patients who feel that opioids burn, and I have never found a way to predict who those people are. And they usually burn equally between both opioids. And I would rely on your nursing colleagues to choose a reasonable concentration for whatever dose you're going to give. Because crucially, which I did not include in this, but your maximum volumes you can put in a butterfly is essentially 2 milliliters per hour. So whatever medications we're choosing, you have to choose based on the concentration of 2 mils per hour can go in a subcut site. And if you're going to use more than 2 mils an hour, we should have more than one subcut site. Now for the death rattle, the anti-secretory, anticholinergic medications, you have actually 2.5 options here, your glycopyrrolate versus your scopolamine. Essentially, they work the same. They have the same mechanism of action. One, glycopyrrolate does not cross the blood-brain barrier and therefore doesn't actually cause any somnolence, whereas scopolamine does cross the blood-brain barrier. It's a mouthful. So whenever I think of scopolamine, I think of sleepy. S for scopolamine, S for sleepy. If you want them to be asleep, so great for your agitated patient at the end of life, put them on scopolamine because you would rather they be sleepy. Versus if you're okay that they're a bit more wakeful, use the glycopyrrolate. There is no evidence that one works better than the other. And certainly there's lots of non-pharmacological stuff for end-of-life secretions. Like if they got like 17 liters of fluid before, then they're going to have secretions, and there's limited stuff that we can do about that. So raise the head of the bed. Usually these patients are NPO, and in the last, I would say 48 hours of life, if we're going to actually use these medications for their secretions, and they should be people who are not taking any food or fluids typically. So yes, scopolamine, sleepy, glycopyrrolate, not, and you can use them together. I've had nurses call me before and say their secretions are really bad. Can we use both? And like, it's not the hill I'm going to die on, I cave, and I say yes. But there is no evidence that even together they work better than separately. If they're having really bad secretions, I would change it to scheduled, and that's kind of the end of it. A note on the atropine ophthalmic drops that you guys have here. This is for patients who are not at the very end of life, who have secretions or drooling from usually a neurological sequelae. So that's your ALS patients, your post-stroke, whatever. So there's less systemic uptake, so you don't get any of the anticholinergic side effects, or less of the anticholinergic side effects. It's also quite a bit less expensive than your subcutaneous scopo or glyco, because scopo and glyco have very poor bioavailability orally. So that's the only real difference between those. And I very rarely use any atropine drops, usually for patients who are being discharged with some sort of neuro thing. And then at the bottom here, we have Tylenol for fever only. Tylenol is no longer for pain because it often has to be given rectally, and that's a lot of work. So in some of the standardized orders, it says pain/fever, and I will often, delete the pain part. So just fever. Agitation at the end of life. This is your order set. And we can talk about some other strategies that I would use, but essentially a similar thing. I like that your order set has all like the non-sedating medications first and the more sedating medications second. So that's kind of a strategy that you can use also. So non-sedating at the top, more sedating at the bottom. Haloperidol, Haldol is one that I like for if you're okay with the patient being more awake, but you just want them to be less agitated in their end-of-life process. I would use haloperidol. Also really good for nausea and vomiting. And a lot of people will be like, but Grace, they're elderly. We have to talk about the black box warning for patients who are elderly with antipsychotics because there is technically an increased risk of death. And that is true, but that is an increased risk of death in the long term. And I am fortunate that I'm using these medications in the short term. So it's not something that I talk about terribly often because it's not terribly relevant to people who are already nearing the end of their lives. And the second medication here, methotrexate or Nozanan, is kind of like our secret sauce in palliative care because it is an antipsychotic, but it works on like many different receptors. The psychiatrists call it really dirty in terms of its receptor use. It has some like anticholinergic effects. It has some, I think it has some SNRI effects too, and then obviously dopaminergic effects. But it just like hits all the things. So we really like Nozanan for the same reason that everybody else really hates it. It is good for delirium. It is good for end-of-life agitation. It is good for sedation. It's good for anxiety. It's good for dyspnea. And it's actually our third-line medication in most cases for breathing. So, just be freely sprinkling Nozanan. I know we're supposed to use the non-brand name names for this, but methotrexate is really a mouthful. So Nozanan in this case, these are very reasonable doses, small to start with. I regularly go up to like 10 milligrams Q4 if I really want someone to be sedated. And then my practice is typically to use midazolam as a rescue medication. So 1 milligram for a small person if they're a big person or have been a big drinker in the past, 2 milligrams PRN for that sedating effect if they're agitated. And of course, when in agitation in all contexts, but certainly at the end of life, we want to make sure that we're eliminating all of those kind of easy to reverse causes. So if they're constipated, they should have a suppository to see if their constipation is really leading to this. If they're having pain, we should have pain treated. check their bladder to see if they're in urinary retention. It happens a lot, et cetera, et cetera. Are they withdrawing from nicotine or any like psych meds? If they're not able to take their psych meds because they've lost their PO route and they are on like tons and tons of psych meds, they can definitely have some really terrible withdrawal symptoms from that as well. And so you might be saying, like, Grace, yes, we have access to these, but sometimes this doesn't work. And the answer is to jack up your doses. So that's option one, jack up your doses, especially of the Nozinan if you want them to be sleepy. Your second option is to use a midazolam infusion. So using that midazolam kind of more regularly. And then if that doesn't work and goals are clearly for comfort, I will start things like phenobarbital. And you can give a loading dose of phenobarbital like 60 or 90 milligrams, and it lasts a long time. So for your perspective, like rather, in your context, you would probably give one dose and then they would be off to whoever's admitting them by the time they need another dose. But that is an option that you can give as well as another line for agitation. Questions about this stuff for agitation, the doses? You're like, what the hell are you doing, Grace? Okay. Hearing none. Oh. Ça va?
J'ai dit tout est clair.
Tout est clair, merci. A quick note on IV fluids, end of life. You know, Emerge loves IV fluids, totally reasonable. It works really well for a lot of people. IV fluids for patients who are dying, of course, cause local irritation, can fall out. Patients who are agitated will pull them out and bleed everywhere. It doesn't provide nutrition, but can prolong, as I say, this phase, the very end of their life. But I worry about the interstitial collection, the edema, the secretions, which can lead to a lot more symptoms. So when patients and families are like, oh, but they're usually actually families, not patients. It's really important to us in our culture to provide some sort of, we can't let them starve or get dehydrated and die. It's important for us to provide some sort of food or fluid. And I say, if I thought the fluids would make them live better, I would do those things. But in my mind, there's no benefit and there's only risk of things like secretions or edema, and that will make them less comfortable. And I would say that, yep.
Can I cut you off for a sec?
Yeah.
There's a question in the chat, which is the most emergency medicine question ever, because we can't have anything without talking about ketamine a little bit.
Okay.
Is there any role for ketamine in sort of end of life? Or have you ever seen it or?
The role for ketamine in my world is for refractory pain. And that's the primary place, or like sometimes existential distress, but very limited for like very end of life, I think. I've never used it in someone who is like kind of in their last 24, 48 hours, if their pain was well managed. So I would say probably not in your context. Does that answer our question?
It does, though most of our patients are having an existential issue after waiting 22 hours. But yes, I think that very much answers the question.
Fair enough. And then you can do what you wish with that existential distress in terms of ketamine, but it would not be my choice for that. And I would say that, you know, in patients who have weeks or months to live, who have refractory pain, there's other things that we can do. Like I'm a big fan of using methadone where possible, which has that kind of an NMDA receptor action, which is similar to ketamine. So we get both the opioid and then the NMDA receptor, a little bit of SNRI receptor. Like I think that works really well. And I usually only use ketamine on patients who are admitted. And I'll admit that I actually don't do it a lot, although I'm moving to the St. Vincent's PCU in the next little bit. So I anticipate I will do it more. I will use it more for my patients there. I will not do it myself. But just back to fluids. At the end of the day, there's lots of cultures who really, really want fluids. And so if that is something that is really important to them, this is not the hill I choose to die on. And I sometimes will run the IV with the understanding that if that IV comes out, I'm not putting it back in. And usually they're like reasonably agreeable to that. But I would start it at a really low rate if possible, because what I find is that people who want the IV for end of life are not actually fussy with how much they get. So I would recommend starting at a very low rate if you think that's ethically reasonable for you. And then they often just like don't notice that we don't change the bag, and then they don't get all the side effects. I see that we have another hand.
Marlène, je pense que tu es sur mute.
Ouais.
Tu es en train de te parler. Là, on t'entend.
Yeah.
Ok,
Salut
bon,
tout le monde.
excusez-moi, Gisèle, infirmière. Donc, je voulais dire que parfois, on
Susanne.
a des accès veineux pour raison X, un nasarque, etc. Est-ce que vous donnez encore des IV, non, pardon, du fluide en sous-cutané?
Presque jamais. Je l'ai jamais fait moi-même. Non,
Mais
c'était
ça se fait.
au début, presque jamais sous-cutané.
Ok, merci.
What I was going to add, so I'm not an emerge doc, I'm one of the ICU docs, but I get this question a lot from patients and mostly their families at this point. The way I get families on board with things like inserting NGs and starting IV fluids is I'll tell them, sort of compare it to when they're sick. So if they have, a flu or whatever, they usually don't want to eat or drink. And so I'll tell them, your family member's body is in a state where they don't really want to eat or drink, and it'll cause them more harm than good, in the sense that they might start to develop symptoms like feel nauseous or start having the secretions and things like that. And generally speaking, most family members accept it. So I don't think I've had to start fluids or feeds on anybody in the last few years by saying it that way.
Well done. Feeds is often a hard stop for me, but I've definitely come into the context where it's like really, really important to have fluids, and this is kind of how I get around it. But certainly part of the counseling is also that like the body is in the natural process of dying. It's starting to shut down. It doesn't need these fluids, and it cannot use them, which is why we're getting all of this edema, these secretions. And we talk about if they're having anasarca, it's coming up and it's like approaching the lungs. We could do real damage and kill them faster if we do that. So that's definitely part of the counseling as well. But I definitely have used the flu analogy, and I think it's a really strong one because everybody knows what it feels like to have the flu and just feel so gross that they don't want to eat or drink anything. Totally relevant. So that's my little speech on food and fluids. So the next two slides are my preferred end of life orders. I don't know if you guys will admit overnight when there's no admitting doctor, but if you're writing admission orders, this is kind of what it would look like for someone who's in their last probably days of life. These are all the common symptoms that we see at the end of life. And the one that I'll highlight here is actually constipation, because even when people are not eating, their bowels often do still have to move from the residual food from when they were more well. So definitely don't forget about constipation, even if they're not eating. So standard end of life orders, private room if possible. We all know that is less possible these days. Stop vital signs. Unless you're really need that for your infection protocol and need to have their temperature taken or whatever, I will allow temperatures to be taken. But really, I try and stop, for example, getting their blood pressure taken if at all possible. Stop IV fluids with the caveats that we've already mentioned, and discontinue IVs unless you're going to use them for a comfort medication. Sometimes I will leave them if we're running infusions and stuff like that. Of course, their goals of care for comfort, stop PO meds. The caveat to the PO meds is if they have a PO route still, then if you are just able to get a couple of medications into them, the medications I prioritize are psychiatric meds, because they'll withdraw from those, and cardiac meds, because we don't have good equivalents for injectable things like beta blockers, which can be for comfort to stop their angina, for example. And then depending on their PO status, to stop meal trays because it's a waste, but leave SIPs for comfort. So the end of life order summary that I use, recall our haloperidol versus our methotrimeprazine for delirium and agitation, haloperidol less sedating, methotrimeprazine more sedating with rescue midazolam if needed, and then check those easy to correct causes, bowels, bladder, withdrawal. For anxiety, 0.5 to 1, probably 1 milligram subcut Q&R PRN. It's also second line for agitation and dyspnea. And then if it's a really big person who's a drinker, 2 milligrams. If they're at a seizure risk, they were on seizure medications and now they've lost their PO route and they're not for IV medications, or if they have a cranial lesion of some sort, something intracranial or mass, midazolam, or whatever your seizure protocol is, but that's my seizure crisis order if needed. And then not to forget about the kind of the moisturizing of the face. So natural tears for their eyes, PRN, and mouth care, QID, and mouth spray, PRN. People are often worried about the feeling of thirst, and we have some reasonable evidence in palliative care that providing IV fluids does not actually help with the feeling of thirst, but mouth care can, so that is helpful. Keep that mouth moist. So this is the opportunity to screenshot this. Oh, we have a hand.
Yeah, I was just wondering, do you target a specific RAS in your order sets? Like someone who has a bit more agitation, do you say like sedate to a RAS -4 or like?
That's a good question. I sedate to symptom management or comfort. So if they're looking comfortable and they're at a RAS of 0, that's fine with me. If they're comfortable or they're not comfortable at 0, then I would aim for harder or for lower. Maybe a -2, but rarely on my orders do I say aim for this level because I'm just aiming for comfort. If they're comfortable at a different RAS level, then that's fine. The exception will come when we're talking about withdrawal of high flow oxygen, and I'm mindful that we only have like 12 minutes left. So this went a lot faster than I thought it was going to. So that's where I would target. If you're withdrawing life-sustaining therapies, high flow oxygen, extubating, blah, 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 then I would target a RAS-PAL of something lower. Awesome, thanks. So second half of the end of life order summary, the other slide to screenshot if you wish. For secretions, we've talked a little bit about this. NPO, raise the head of the bed. They should not be on additional fluids if we're giving these medications, and typically mainly in the last 24, 48 hours of life. The glycopyrrolate, less sedating, scopolamine, more sedating. For pain and dyspnea, oxygen for comfort only. I really try to not focus the oxygen on their saturations. And then these are some starting opioid doses. But of course, if they are already on opioids, not naive, then you would just use their previous dose or escalate by 20% if you wanted to raise the dose, if you wished. And choose whichever one you like or whichever they were on before. For nausea, metoclopramide or Maxaran, 10 milligrams subcut Q4R PRN, but the haloperidol or the methyltrimiprazine, if you're using that for their agitation, will also do the trick. All the anti-dopaminergic medications are powerful anti-nausea medications. So I actually use quite a bit of antipsychotics for nausea in my practice, especially if I'm at all worried that there could be a bowel obstruction, which makes metoclopramide contraindicated. And then, of course, the last little bit, if they have dyspepsia, you can actually give ranitidine subcutaneous, fun fact. I think it's on back order, which is why I have famotidine here, which is an equivalent, probably not so relevant in the emergency room context, but good to know. Suppositories for daily PRN for possible constipation. I think it's very important, especially if they're agitated. Foley catheter for comfort, and Tylenol for fevers only. Screenshot at will. Okay, questions before we continue with this happy owl who has made all of the best symptom management choices. Okay. I'm gonna probably kind of zoom through the withdrawal of high flow oxygen, which I know was a goal of ours, but it is quite nuanced. So I'm gonna provide some papers also if people are super interested. So what if our friend Mr. H had initially been started on Airvo or BiPAP in the kind of hustle and bustle and confusion before his wife got there? But once his wife gets there, she's like, no, we talked about this. He does not want non-invasive ventilation. He's been on BiPAP before with his COPD exacerbations back in the day. That was really horrible. We want you to take this away. So that is an indication to withdraw from high flow. And this is kind of my checklist for withdrawing high flow. And we can talk about some medications and resources as well with the time that we have. So first things first, educating the patients and the families or whoever's going to be there during the wean process about kind of like, what is it going to look like? What are we going to do? How long is it going to take? What are the medications we're going to use for comfort and dignity? And what are the signs that they might see? Are they going to see, because people are really worried they're going to see choking or like big gasp and that people are going to be horribly short of breath. So you can counsel on like some noise is okay. We're aiming for sleepiness, not agitation, comfort, kind of slow and regular respirations. The biggest thing I counsel about when I'm doing a wean is the time. So number 2 there. And so depending on the patient's dependence on that level of, I'm going to call it life support, high flow. In this context, the prognosis can be widely variable, and our ICU colleagues will be well aware of this. But if you withdraw BiPAP or high flow or decrease it, I would say about 50% of patients die within 4-ish to 6-ish hours. 75% will die within 12 hours. But that last 25% can go for like even a couple of days sometimes and sometimes longer. And I think that family members think that we're going to take away the oxygen and then they're going to be comfortable and die like right now when they're here and they're ready. We're going to do it now. And then they get very worried, anxious that something is wrong if it lasts a lot longer, and it really can last a lot longer. So I prepare them for that possibility. And I think that that's super important. If they're on an opioid, increase it. If they're not on an opioid, start it. And I use a midazolam CAD, usually IV as an infusion for sedation purposes when we're withdrawing high flow. And then, of course, making generous doses of PRN and sedating medications available. We have to make sure that the patient appears comfortable and hopefully is comfortable before we actually start weaning any of the oxygen from a high flow perspective. And so I will usually give my boluses or start my medications, ensure that I feel that they're comfortable, and then with myself or directing respiratory therapy to start weaning the high flow, 30% at a time kind of thing. And then every time that we step down on the high flow, check for comfort for at least a couple of minutes to make sure that they're tolerating that level on the medications that they're on. I do recommend using a scoring system, and I think it was Zachary who pointed out that asked about the RAS-PAL or the RAS, and I'll show you some of the scoring systems, but I use the RAS-PAL on the next slide. And then importantly, if you're going to be changing the doses of your infusions or giving PRNs, I think that a simple documentation like you would use in a code, like what time, what was the indication for changing the medication or giving a PRN. I think that's, good, prudent medical legal charting. So RAS-PAL +2 or increased work of breathing, infusion increased to whatever, I think is good and prudent charting. There are no validated specific tools for monitoring distress in these withdrawal situations, but you can use the critical care pain observation tool, the respiratory distress observation scale, but I typically will use the Richmond Assessment Sedation Scale, or the RAS, and there is a RAS palliative version that I use. In addition to my general gestalt on their work of breathing, their comfort as from a dyspnea perspective. This is the RAS-PAL. I usually aim for kind of -3, where some movement is okay, but kind of no purposeful eye contact or movement. If a patient does become restless or uncomfortable or displaying work of breathing, then I would return to my previous oxygen settings, optimize their medications, and then try again. And sometimes we get to a place where they cannot be decreased anymore. And so I would just leave it there at that point. We've weaned all we can. We are going for comfort as our primary end point in this context. You'll be happy to know that there are some guidelines for managing this type of thing. It is mostly in the critical care literature, but this was a Delphi process of 35 MDs and RNs who developed some guidelines for withdrawal of life-sustaining measures. This is primarily intubated patients, but I think the principles still apply to non-invasive withdrawal. And also is an interesting read on the like ethical considerations of withdrawing life support. Go ahead, Diana.
Yeah, so this may be a stupid question because like I feel like I'm quite comfortable approaching the topic of palliation and stuff, especially in a lot of these old people with pneumonia, COPD, like the kind of respiratory illness. And I've never the BiPAP is not comfortable. You can see it. It's like leaving welts on their face and stuff. So it's really easy to say, I think we want to take this off. It's suffocating and stuff. But I've never weaned the oxygen. I've just continued with the meds. I didn't like it, I was under the impression that the oxygen was like that high flow oxygen made people more comfortable, so that it was, and I didn't even know. So the goals of decreasing it is because it's prolonging life unnecessarily, or just because it's loud and it's whistling? Like I'm not like, it sounds silly, but what's the goal in even bothering to wean the oxygen? I totally understand taking away BiPAP.
Totally great question. The high flow like Airvo is like loud, it's blowy, and it is prolonging again that phase of a person's life. So if a family is not interested in prolonging that phase of their life, or actually I have this conversation often with patients and they're like, listen, I know the end is coming, I'm ready, let's go. That is the context in which I would withdraw. If no one is asking you to withdraw, I don't think there's no need to do that. But if this is in the context of someone saying like, no, this treatment is not within my goals of care, I want you to take it away. This is how we can do it in a comfortable and dignified manner. But if you want to keep the Airvo going, and if they're okay with that, I'm okay with that.
Gotcha. Okay. And even just like high flow nasal prongs kind of thing. Sometimes they just look more comfortable, I find a lot of times, but
it's fair.
But maybe they need more meds.
They might just need more meds. If this is particularly in the context of a patient whose goals are like purely for comfort. I think that my personal perspective is that high flow is not like intrinsically comfortable. It's not as bad as BiPAP, but it's not intrinsically comfortable. So they might just need more meds in that context. And I would invite you to try that if you felt that was within your practice, to maybe increase a little bit more sedation if they're interested in that, increase their opioids a little bit more if they're interested in that. Because then we could have the less kind of blowy. I try to get people down to like regular nasal prongs at like less than 10, ideally less than kind of 6 liters per minute. Because then it's not the loud shooting air and it's distressing for everybody, but totally okay, especially in the emergency room overnight when you're by yourself, totally okay to leave those on.
Grace, I think I'll just stop you there because it's 8:59 and see if there's any questions. Maybe just go throw it down the resources, yeah.
Yeah, here's the resources. The one I want to highlight, or the two I want to highlight, are the Serious Illness Conversation Guides, CPSBC. And then if you are an emergency doc who likes to have one-pagers on stuff that is supported by evidence, I would recommend the Palliative Care Network of Wisconsin Palliative Care Fast Facts. And this is their one-pager on the death rattle. And this is the second half of it. It has a background, it has some pharmacological, non-pharmacological, and then all of the citations, very evidence-based. Look it up, Fast Facts. All right, I'm going to stop sharing my screen here.
Go ahead, Jordy.
Hey, can you hear me okay?
Yeah.
So more of just a quick comment. A fantastic talk. Thank you for the resources. I tried to refer a neighbor of mine who another neighbor came to get help in terms of palliating her. And your outpatient referral via that ocean is garbage. I'm sorry. I really tried to get a rapid, home care type of thing. But just to let you know that if you have someone who's not within your network try to refer, was just a horrible nightmare. So the rest of it in terms of getting the home care stuff was good, but I wanted to get her home palliative care, and it's just really, really, really tricky to navigate. So that's my only comment, but great talk. Thank you for the great resources.
Absolutely. The community takeover teams are not part of my division, but I can definitely feed that back to them. And I think most of them have fax numbers. If you ever really needed to get hold of them, they'll accept referrals outside of Ocean also.
Vas-y, Francis.
Just quick comment on that. Just a reminder for all our team, anyone that's going back home, our palliative care team will set up with every palliative care team in Ottawa for next steps. So if you're sending someone home, and our palliative care team will take over the next day and will arrange. They will contact whoever will be the catchment area and make sure that that patient is referred. So if there's a willingness and wanting to go home, you can just put a pink sheet in, same thing as our GEM consult bin, and then palliative care team comes and seeks those out and will arrange for in-home, which whoever the team is most appropriate for that patient, depending on the area.
And just one last comment for me. Grace asked me if we could just, Grace likes feedback, so sometimes on l'oublie de remplir le formulaire de feedback. N'importe quoi pour Grace, ça serait grandement apprécié.
Indeed. Would it be helpful to have this presentation?
Yeah, if you could send it to me, that would be awesome. Thanks again, Grace. That was really, really wonderful.
I'll put my email or my email's in the presentation, but I'll try and throw it in the chat as well. So if people have specific questions, I'm delighted to kind of field them by email as well afterwards. I can't open the chat for some reason right now, so we'll figure that out.
Merci beaucoup, Grace.
Merci.
Merci.
Merci beaucoup.
Bonne journée, everybody.
Thank you.